All right, so just gonna tell you now, we're at hockey, so you're gonna hear some hockey sounds, but hopefully this will record well enough so that we can get through this information. What we have is we have 5 patients here, and each one of these patients has a different diagnosis. We're gonna start with our friend up at the top here, who has prostate cancer. And then we have our friend down here who has multiple myeloma. And we go down to this bottom friend, and he has lung cancer, colon cancer. Oops, I erased it. That was weird. Okay, and then our final patient, so we've got prostate, multiple myeloma, lung cancer, colon cancer, and our final patient is gonna have, I don't know, skin cancer. Okay, so we have 4 very different patients. Actually, never mind. I'm not going to give them skin cancer because that's boring. Yeah, that's an easy one. We're going to give them a glioblastoma. Bad day for this guy. Okay, so now what we're going to do is we're going to go through, we're going to talk about how is each one of these diagnosed? What are the things that are going to bring patients in to a clinic or a hospital that are going to get us noticed and getting us start down that diagnosis path? So with prostate cancer, you might have urgency, right? Comes into the doctor's office and is complaining, I don't know what's going on, I keep getting up and peeing all the time. Maybe he has erectile dysfunction, so ED, unable to, participate in sexual activities with his partner, or along with the urgency, feels like he has to go to the bathroom but has hesitancy, and so the inability to void when he needs to. So that's all stuff that would get you into prostate cancer. All right. Multiple myeloma is a cancer of plasma. So what we have to understand about multiple myeloma is where it is. And actually, we can go back to the prostate. We can talk about the prostate is in here. The multiple myeloma is in the bone. Okay, because that is where our blood products are made. It's in that bone marrow. So when we think about what's going to bring in our multiple myeloma patients, it's going to be fatigue, which is kind of generic, pain. But where is that pain going to be located? It's going to be bone pain. These are going to be patients that are having a lot of discomfort and a lot of pain in their bone. Sometimes it'll be a random fracture, and it'll be a fracture from something that shouldn't have been a fracture. Like they, tripped on the rug and fell on the bed and broke their arm. Like, what the heck? That amount of force should not break an arm. So that's something that we'd have to pay attention to. Because of how myeloma is in the bone, it slowly eats like holes in the bone. It has problems with the calcium absorption and all that kind of stuff. So thinking about our multiple myeloma patients, bone pain is huge and fractures are frequent. So let's talk about our lung cancer patient. What are they going to come in with? That nagging cough. All right, they have a nagging cough that just won't go away. Sometimes they'll have that weight loss. Okay, they might start looking really thin or failure to thrive issues because they're having so much weight loss. Short of breath, frequent. Sometimes with that nagging cough, they can be coughing up sputum or blood tinged. So that's not uncommon. So our lung cancer, it's going to be somewhere in here. All right. That's what's going to bring in a lung cancer patient. Then we go over to our colon cancer patient. So it's somewhere in there is the tumor. And then what's going to bring them in? It's going to be a change in bowel pattern is often what we see. They might be having some issues with constipation or diarrhea, depending on what they're going through. Oh, I hate diarrhea. I can never spell it. Gosh, liquid poo. Okay. Anyways, so our colon cancer patients, they also might be having, because that tumor is putting pressure in the belly, they might have issues with their bladder. They might have issues with distension, anything that can happen inside that belly space. So, and this colon cancer can get really large before we realize they have it. All right. And now our glioblastoma. So what is a glioblastoma? So we've got oma, so we know it's a tumor. Blast is a cell or a young cell. And glio, that's in the brain. So a glioblastoma is going to be a tumor that's somewhere in the brain causing a lot of complications and difficulty. What's going to bring somebody in with a glio? So it's going to be like mental status changes. So mental change or level of consciousness change, seizures. It might be something, confusion, or anything that might look like a stroke might also be causing some glioblastoma issues. So they might come in and be like, man, my arm, I can't lift it anymore. Something's wrong, right? Because where is that glio being pushing? It's pushing and putting pressure inside that skull, and it's squishing the brain, squishing the brain against the skull as it grows. And so it can become a really big problem depending on how big it's gotten. And glios are unfortunately a hard one for people to survive. They're usually really aggressive and they're really fast growing. So those are kind of the things that we would see these people come in with. Now, we're going to start getting ready to diagnose them, right? Because I've come in with these signs and symptoms and we have no idea what they really have, even though I already told you what they have. So now we're going to talk about what we like to do in medicine is we like to rule stuff out. So we rule out other things. With prostate cancer, things like if you have erectile dysfunction, that may be just from a lot of stress at work. So we need to rule stuff out. So it's important to take a good health history on that patient. We're probably going to have some sort of digital rectal exam where the doctor goes in and feels, because you can feel the prostate through the rectal wall. Another thing they might do is a PSA, which is a lab draw, and it stands for prostate specific antigen. And when that gets above a 4, we know that we have some sort of prostate hypertrophy going on, meaning that prostate is getting larger. Now, it can be benign prostate hypertrophy, or it can be cancerous. We don't know what until we actually get that biopsy tissue, right? So, leading to our next spot, we need to get a biopsy. How are we going to get a biopsy of a prostate? Is they actually usually go in through the urethral opening, and they go up and they do a little clipping. So it's usually called a cystoscopy. So it's a scope that goes up, and they'll go up and get a little snippet of it and bring it out and look at it. So that's how we would get that biopsy, right? Because every single one of these patients, we got to have a biopsy. We got to get that tissue. All right, with our multiple myeloma patient, we want to get a history, right? I mean, if they come in with a fracture, we got to figure out what's going on, right? So we're going to get an x-ray, right? We want an x-ray of those bones. And that's when we'll start to see like there's some holes. Because remember, when it comes to this, these guys start getting holes and their bones start to look kind of like Swiss cheese as that cancer grows and metabolizes the calcium. Some students today came up with, it's called CRAB. And so what that stands for is calcium, renal issues, anemia, and drawing a blank on the butt, and bone. Okay, so that bone pain. So they may say CRAB, which is kind of interesting, but it doesn't really change what we're doing. We're getting a good history of them. We're getting an x-ray of the bone area. We may see stuff going on. We're probably going to get some labs. So we're probably going to get a CBC, right? Because we want to look at the platelets, plasma, hemoglobin, hematocrit, white blood cells, red blood cells, all that kind of stuff, because all of that stuff is made in the bone marrow. How are we getting a biopsy on this person? We're doing a bone marrow biopsy. So this is that needle. They're going to stick into like the pelvis area and pull some of it, aspirate some of it back, and then they're going to run it to the lab and to the pathology and look at it. Okay, so this is how they're going to get their biopsy. So lung cancer, nagging cough, weight loss, thin, failure to thrive, shortness of breath. First things I'm going to want, we're going to get a history, because what do I want to know about? I want to know their smoking history. I want to know their exposure history. Have they been a good old Navy boy and had a lot of asbestos and that kind of stuff? Or have they been, are they maybe getting a lot of radon exposure? Who knows? Or smoking. Smoking is the #1 cause for lung cancer. And I'm sure with all the vaping, we're going to have some interesting cancers start coming from that. So we want that history. I'm probably going to want a set of vital signs relatively quickly, because I want to know the SpO2, right? If they are below 90%, we need to start, our speed starts getting a little faster. We need to start doing something a little quicker to get them oxygenated and get them going. Other things that we're going to do with them, we may do some labs. We may do an ABG, which is an arterial blood gas. You might, they're probably gonna run labs on them just to check everything, but that wouldn't necessarily go specific. The question is, how do they get the biopsy for this person? For this person, they're gonna get that biopsy. They're gonna do a bronchoscopy. And that means we're gonna go down the trachea, down the mouth, down the trachea, and into the lungs to get some of that tissue out. And when we get some of that tissue out, and they might get out some of the sputum and all that kind of stuff, wash it out, and they'll send that to pathology. So this is a scope, okay, and it's down into the bronchus. Think about things that we do that keep our airways safe, like swallow. They're not going to be able to swallow, right, because we've probably numbed their throat, and so now we need to make sure, one, they can't swallow beforehand, right? The numbing medication has worked, but we also need to make sure when they come back that they have their swallow or their gag has returned. We want that back. If we don't have that back, we can't give meds, we can't give food. So no meds, no food, no nothing, no sips of water for their sore throat, no ice chips, no nothing until they get that gag back. Really important, before the procedure, they're going to be NPO, right? Because we don't want anything down there to risk aspiration on. So we've talked about their biopsy. It's going to be down the bronchoscopy. That's how we're going to get some of that. They may go in externally and stab a needle in there and pull out some if they think the cancer's on the outside of the lungs. They may have to go from the outside of the lungs to get the tissue, but a lot of times the bronchoscopy will work. So let's go over to colon cancer. What do we want to do? We want a history. One, I want to know what their normal pattern is. So everybody has a different pattern for stooling, and we want to know what their normal pattern is, because you and I do not have the same pattern, and knowing that there's something different is really important to us being able to help them and understand where things have changed. We also want to know if there's any blood in the stool. All right, so it's really important that we look for that. Other things we might want to do, you could do some vital signs, that wouldn't hurt. Our labs aren't going to really show us anything, so we really want to get a colonoscopy on this person, where we go in, again, scopy, so we're going in with a video camera. Colon is where we're going. So that tells us we're going to go in, and this is how we're going to get our biopsy, is we're going to get that ready. Now, prepping somebody for colonoscopy is going to be different than prepping somebody for a bronchoscopy, right? Because this one, you're going down the lungs, you're going down the throat, right? This one, you're going up the rump. And so different kind of prep. For this prep, we're going to be doing some sort of movie prep or bowel prep to get, we want them clear and cleaned out. We want their stool to be clear. It's really important. You cannot see through stool, so we have to get them cleared out. Versus with our bronchoscopy, we don't want them cleared out, right? We want their lungs and throat cleared out and their stomach cleared out, but not necessarily their bowel. We don't care so much about the bowel for bronchoscopy. Colonoscopy, we care about the bowel and we want it cleared out. So really important that we get them clear. Sometimes we'll have to put an NG down them so that we can give them the movie prep or the bowel prep or the Go Lightly or whatever stuff they're using, because people don't like it. It's gross. That's my best drawing for somebody not liking it. And so we have to make sure that we're finding ways to get this done. So biopsy for this, for colon, is colonoscopy. You gotta get that movie prep in. There's still gonna be NPO because we're gonna give them sedation after they've had all their bowel prep kind of stuff. So anybody that's getting some sort of scope is usually gonna have some sort of sedation, and they're gonna be NPO for that type of procedure, but we wanna make sure that bowel's cleaned out. All right, so our glio, how are we going to check? How are we going to take care of him? Well, one, it changes. If this patient is having seizures and we are in a clinic, we are calling 911. Don't pass go, don't pay the $200, call 911, get help. Safety becomes a huge issue for this. If you have somebody that is coming in just for some confusion, that's the person that we're probably going to get set up for an MRI or a CT scan or something like that. We want to have a visualization of what's going on. Remember what an MRI is versus a CT scan. They are different. They require different prep work. One has radiation. One has a giant magnet. Giant magnet pulls things out. So really important that we assess somebody for if they have any metal in their body. We do not want them going into an MRI machine. So make sure you're paying attention to that stuff depending on what we're getting done. CT, radiation. Anytime we have radiation going into somebody, I want to know if they're pregnant or when they could have been pregnant. All right. But if you're coming in for confusion, that usually is a slower process and we can take care of it. If we're having seizures, we need to keep them safe. We need to make sure they're not hitting their head on anything. Don't put them on that like high table at the doctor's office. How are we going to get this biopsy? This biopsy is going to be a surgery. Okay. This person, if they're going in for this is an actual surgery that they're going to have done. And so it's really important if we're having somebody get prepping for surgery. Again, we have those NPO orders. We have consent that we have to work with. And they may not be able to sign their own consent because if they've got their brain being crushed against their skull, they may not be oriented. So we may have to have family. We may have to have a POA lined up. It just really depends on where they are in the stage of their glioblastoma. So we talked about rule out is what we're going to do with a lot of the things we do. A lot of the scans we do, a lot of the procedures we do are looking to rule something out. So like with your lung cancer, you're going to rule out pneumonia. Maybe they're coming in for pneumonia, but the pneumonia is secondary to the lung cancer that's going on. The next thing we need to do is we've got to get a biopsy. We got to figure out how are we going to get that biopsy, because that biopsy changes in between each patient. And then we're going to do different surgeries. Okay, so when we're talking about treatments, let's see if I can rate this with a fancier color here. If we're going to do treatments, we're going to usually do some sort of surgery, chemo, and radiation. And those are going to be decided by people who make a lot more money than you and I do. And they are going to figure out, but they cannot do this until they rule out other stuff. They get biopsies of the tissue, and then we can make a treatment plan. But you can see how each one of these presents a little bit different. each one of these, the biopsy is gotten a little bit differently. And so that means that our nursing care changes. So things to think about as you're working with cancer patients is, how does my nursing care change with the diagnosis? Okay, how does it change? How is it unique to this patient? And a big one, let's see if I can make this pen bigger, is priority. Is what is the priority? Is the priority safety at this moment? Well, if they've got confusion, maybe a little, but not as big as getting them diagnosed. Other things that we need to think of is, what data do I need to make decisions? Okay. Okay. What data do you need to make the decisions about each one of these patients? Because each one is different. Each one has cancer, right? But each cancer is different and requires different functions and different tasks. Thanks for hanging out with me for a little bit at hockey practice, and looks like the Zamboni's out, so it means time to go. Have a great time, and we'll see you in class.